Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's discussion is on surgical aspects of typhoid fever. It is an important infection of surgical importance in tropical and developing countries. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, don't forget to press the bell icon below to get my videos regularly. Typhoid fever or enteric fever is an acute systemic infection characterized by prolonged fever and abdominal pain. It is caused primarily by a gram-negative bacillus called Salmonella typhi. The mean incubation period of Salmonella typhi is 10 to 14 days. Poor hygiene and inadequate sanitation are main predisposing factors. The clinical features of enteric fever include maculopapular, salmon-colored, rose spot rash, hepatosplenomegaly, epistaxis, and relative bradycardia. Salmonella can be cultured from punch biopsy of the rash. In the surgical arena, the typhoid fever causes an enteritis that may lead to perforation of an intestinal typhoid ulcer and a serious peritonitis. Neurological complications such as meningitis, Guillain-Barré syndrome, and neuropsychiatric symptoms like muttering delirium or comavigil may also occur. 2 to 5% patients become chronic asymptomatic carriers, releasing Salmonella typhi in either urine or stool for more than 1 year. Chronic carrier state is more common among women. The organism enters the gut along with contaminated food or water and colonizes the peyerspatches in the terminalileum, causing hyperplasia, necrosis, and ulceration. Intestinal perforation and bleeding through ulcerated ileocecal peyerspatches most commonly occur in the second and third weeks of illness in approximately 2% of cases. The commonest site of enteric perforation is the terminal ileum. A sudden deterioration accompanied by severe generalized abdominal pain and signs of peritonitis in the second or third week of the illness indicates a perforated typhoid ulcer unless proven otherwise. Resulting peritonitis makes the patient critically ill. Both complications are life-threatening and require immediate fluid resuscitation and surgical intervention. Microscopically, there is erythrophagocytosis and histiocytic proliferation in the lymphoid follicles. If the treatment is delayed or inadequate, the ulcers may perforate and bleed, leading to multiple site bowel perforations, including the large bowel. Typically, there may be a history of recent visit to an endemic area or country. Patient suffers from a high temperature for 2 to 3 weeks with a toxic look and abdominal distension due to paralytic ileus. He may have melena due to bleeding from a typhoid ulcer, which, if severe, may lead to hypovolemia and shock. The definitive diagnosis of enteric fever requires the isolation of Salmonella typhi and paratyphi from blood, bone marrow, rose spots, stool, or intestinal secretions. Blood and stool cultures confirm the type of infection. Combining blood and urine cultures achieves a sensitivity of 82% and a specificity of 100%. Bone marrow culture is more than 80% sensitive. Unlike that of blood culture, bone marrow culture sensitivity is not reduced by up to 5 days of prior antibiotic therapy. Other than a positive culture, no laboratory test is confirmatory for enteric fever. The Vidal test for the presence of agglutinins 2O and H antigens of Salmonella typhi and paratyphi in the patient's serum is still done in Indian subcontinent, but it lacks a specificity. Modern laboratories perform more sensitive and specific tests for rapid detection, such as multi-test DIP-S-TICS to detect immunoglobulin G, Tubex to detect immunoglobulin M, and Typhoid to detect IgG and IgM. These tests are valuable If culture and sensitivity tests are negative due to pre-hospital treatment or self-medication with antibiotics, or facilities for culture and sensitivity tests are not available, 15 to 25% of cases develop leukopenia and neutropenia. Leukocytosis is more common among children and in the presence of intestinal perforation or secondary infection. An erect chest radiograph or a lateral decubitus film in a very ill patient shows free gas under the diaphragm or in the peritoneal cavity, respectively. Timely resuscitation with intravenous fluids and antibiotics with prompt surgical management gives the best chance of improving the patient's condition and survival. Metronidazole, ciprofloxacin, and gentamicin combination is usually used after sensitivity testing. Ciprofloxacin is the most effective drug with cure rates of about 98%. Ceftriaxone, cefotaxime, and cefixime are effective for treatment of multi-drug resistant enteric fever, including that caused by ciprofloxacin resistant DSC strains. Chloramphenicol is rarely used nowadays due to its potential side effect of aplastic anemia. In confirmed cases of perforation, a laparotomy is carried out after hemodynamic resuscitation. Operative procedure is chosen judiciously depending upon the general condition of the patient, the site of perforation, the number of perforations, and the degree of peritoneal contamination. The options are simple closure of the perforation after freshening of edges, wedge resection and repair of the gut bearing the ulcer, bowel resection and end-to-end anastomosis, closure of the perforation and side-to-side iliotransverse anastomosis, exteriorization of the bowel, and ileostomy or colostomy as necessary. In the end, another search is carried out to look for any leftover perforation or impending perforation sites and should be dealt with appropriately if found. A thorough peritoneal lavage is essential. Post-operative wound infection is almost inevitable and dehiscence or burst abdomen are not uncommon.